Welcome, students. I'm Dr. Abhinav from Department of Prosthodontics. Mine's Mahi. So today I'm going to discuss a very short topic for final year students on combination syndrome and its associated changes. So this has got a lot of significance because you get to see a lot of cases coming to your practice or to the department, maybe such situations. So what is combination syndrome? So this was first introduced by Kelly in the year 1972. So this is also called as Kelly syndrome, and it is also known as anterior hyperfunction syndrome. So there are certain classic features which we get to see in a combination syndrome. Before we start off with anything, let me make it very clear what a combination syndrome is. So when you get a situation where the patient reports to you with a complete loss of maxillary teeth, that is an edentulous maxilla, completely edentulous maxilla, along with few remaining lower anterior teeth, that is all the posterior teeth in the mandible are missing. So just like a bilateral edentulous situation of Kennedy's class 1. So this is what we call as a combination syndrome. So when a patient ends up with a situation like this, there are certain things. Once this patient starts eating or getting accustomed to this clinical condition, there are certain changes that happen in the oral cavity. So let's see what are they and what are those features. So when such situation happen, there will be a lot of destructive problems that may be encountered as a result of long-term use of your mandibular distal extension partial denture against your maxillary complete denture. So that's what is being described by Kelly in your combination syndrome. So the syndrome consists of loss of bone from the maxillary anterior edentulous ridge, downgrowth of maxillary tuberosities, papillary hyperplasia of the tissues of hard palate, extrusion of lower anterior teeth, and loss of bone beneath the RPD basis. And it is usually associated with 6 changes, that is loss of vertical dimension of occlusion, occlusal plane discrepancy, anterior spatial resorption of the mandible, development of epulis fissuratum, poor adaptation of the processes, and periodontal changes. So let us see one by one what happens when you have certain clinical changes. So to start with, your loss of bone from the maxillary anterior edentulous ridge. What could be the reason for this loss of bone at the maxillary edentulous ridge? So first of all, we know that at this stage of the patient is completely edentulous. There is no teeth in the maxillary arch. There is complete loss of teeth in the maxillary arch. At the same time, the mandibular lower anterior teeth are present. So the patient tends to bite, protrude the mandible, and tends to bite with the ridge, towards the ridge, to get that proprioception of a bite, because the few remaining natural teeth are situated at the lower anterior region. So because of which there is an increased force transmitted onto the maxillary ridge, anterior area, premaxillary area. So because of this excessive force acting or being incident on this premaxillary region, this can result in a good amount of resorption, residual ridge resorption, which normally takes place, but because its speed or it might be accelerated because of the stress which is being seen because of the lower anterior touching the maxillary anterior ridge. So because of which there will be a rapid amount of resorption resulting in a flabby ridge situation, and even the dentures, once being fabricated, will not be having adequate support from the ridge, which results in chronic pushing of the denture towards the labial sulcus and creating an irritation, which finally results in a condition called as epulis fissuratum and a lot of resorption in the maxillary plane, maxillary anterior maxillary ridge. Same time, it is also associated with downgrowth of maxillary tuberosity. It is not just a bony prominence. The tuberosity's growth is mainly a fibrous type. It is not of a bony type of overgrowth. It's like a fibrous overgrowth of the tuberosity, creating a situation where the maxillary plane anteriorly has gone up because of the excessive resorption, and posteriorly because of the enlargement of the tuberosities, the plane has come down. So there is an inversion of maxillary occlusal plane. So at the same time, we have papillary hyperplasia of the tissues of hard palate because of the consistent forces. The movement and rocking of the dentures can create a consistent stress pressure onto the papillae, and finally it can result in papillary hyperplasia of tissues and rugae area, as well as there will be a lot of irritation. At the same time, because of there is no counterpart or opposite side teeth in the maxillary arch, the lower anterior mandibular teeth tends to supra-erupt. So that results in an extrusion of your lower anterior teeth. And at the same time, because of this lower anteriors, the plane has come down the posterior teeth. In mandible, the condition is like Kennedy's class 1 situation. So there are no posterior teeth available for mastication. All the forces has been transmitted. Because of this, the entire force is coming right now from the anterior region. No posterior teeth are there, but when the patient starts using a denture in maxilla, because of the growth of the tuberosities, the plane is inverted. So that means there is very less space for the mandibular posterior teeth to be placed in a removable partial denture, because of which the patient, while doing the protrusive or lateral excursive motions or movements, will end up in a lot of interferences, occlusal interferences, resulting in unwanted forces over the residual ridge area of mandible, and finally it results in a good amount of residual ridge resorption. So you get to see a situation. The final results, what we get to have is a resorbed maxilla, premaxilla in the patient, and a resorbed mandibular posterior ridge in the lower arch. So as we have already mentioned, the after effects of these things are the loss of vertical dimension of occlusion, occlusal plane discrepancy, the spatial resorption of mandible, development of epulis. And because of this, the consistent nature of force transmitted, the lack of support from the denture bearing area, there is poor adaptation of the processes most often, and even the lower anteriors could be because of the consistent loading of the lower anteriors, which is not intended to take up a masticatory load, may result in periodontal changes, and finally the patient might end up in losing the teeth. So this is what is a pictorial representations. Here you can see the maxillary denture opposing the lower anterior teeth, and you can see the inversion of the plane, that the anterior forces coming and the denture being tipping at the posterior region. So what we do, we give a processes. You have the RPD at the posterior region, which sits there because of the lack of the plane. There could be a lot of occlusal interferences. So what we have to keep in mind when we discuss about the combination syndrome is, first, what is the type of clinical situation? Like we have an edentulous maxilla and a Kennedy's class 1 or bilateral edentulous posterior area in mandible. So what are the changes associated, chronic changes associated with such situation is, because of the lack of any teeth present in maxilla, the anterior teeth there in the patient, in order to achieve that proprioception, patient tends to bite forward in a protrusive manner, even not coming onto the centric relation position. So because of which there will be enhanced residual ridge resorption in maxilla, inversion of the occlusal plane at the max anterior region, enlargement of tuberosity and downward growth or fibrous growth of tuberosity, creating an inversion of occlusal plane in the posterior aspect, which results in a reduced occlusal restorative space for the mandibular teeth, which finally being given will result in interferences that will create a lot of stress onto the ridge and resorption of the posterior edentulous area in the mandible, and supraeruption of lower anterior teeth, papillary hyperplasia, epulis fissuratum because of the unsettling of the denture because of the consistent stresses and the nature of the occlusal plane. So these are the things which we have to keep in mind. And once more, how to manage. The most important thing is prevention. It is always prevention is better than cure. So we have to educate and motivate our patients who come to our practice and ask us to get the posterior teeth extracted, which could be saved. So we can make sure we don't leave the patient to end up in a situation like this, which may be very difficult, and the patient may even finally result in having a lack of efficiency in chewing. So finally, so the best option in order to prevent the situation is to maintain the posterior teeth, give the patient sufficient information what are the problems that he's going to face when once the teeth are being removed, and try to save them by doing endodontic procedures, periodontal procedures, and prosthetically try to rehabilitate them without extraction. And once if the patient is reported already with such a situation, we'll have to correct the occlusal plane, maybe by doing intentional endodontic procedures for the lower anteriors, maybe by doing a grafting at the maxillary, premaxillary region. We can use soft tissue grafting and hard tissue grafting techniques. We can do a correction of the tuberosities, the enlarged tuberosities. We can try to place implants at the posterior, dental implants, which tends to prevent or which can control the rate of resorption at the posterior region and give a better occlusion and better plane, occlusal plane, as well as masticatory efficiency for the patient. So these are the various things regarding combination syndrome. I hope you all understood what are the reasons why do we call them as combination syndrome. To call as a syndrome, there should be certain clinical features which are associated with a particular thing, then an etiology behind it, why this is happening. So this is what is combination syndrome, which is put forward by Ellsworth Kelly in 1972, and we also call it as anterior hyperfunction syndrome. And this is a very important short note question for the final year as far as their academic point of view. And I hope this would be very beneficial for the students to answer for their final exams. Thank you.